Good afternoon, all. I am Dr. Amruta Ekbote from Assistant Professor in Kinesiotherapy and Physical Diagnosis Department, Sancheti Institute College of Physiotherapy. I'll be taking, in today's PhysioTV classroom, I'll be taking a session on coordination. So as we all know, for any action to be carried out, as simple as lifting a glass of water, we need a sequence of movements to perform the action so as the lifting of the glass becomes smooth. The action which is required for the smooth functioning or smooth sequencing of all the movements is called coordination. So let's see the definition of coordination. So coordination is the ability to execute smooth, accurate, and controlled movement, right? It also involves multiple joints and muscles that are activated at appropriate time and with the correct amount of force so that smooth, efficient, and accurate movement occurs. Okay, so what basic coordination is, if I want to lift a glass of water from a certain distance on the table, I will have to carry out a certain amount of flexion of the upper limb, right? Certain amount of certain amount of force of the grasp, and I will also have to judge the distance that is of the glass from my body, right? So these sequence of movements that occur in which is involved in lifting of the glass of water is known as coordination. They are characterized by appropriate speed, distance, direction, timing, and muscular tension. So these are the 5 characteristics according to which any coordinated movement can be defined, which is speed, distance, direction, timing, and muscular tension. Okay. In addition, they involve appropriate synergistic influences. Now, synergistic influences in the sense that the muscle which is required, how much or for how long it should be recruited, easy reversal between opposing muscle groups, that is alternating between contraction and relaxation. So it can be any of the 2 movements that are occurring, and proximal fixation to allow distal motion or maintenance of a posture. For example, if I'm doing an action of reaching, right? So for me to be able to do an action of reaching, my proximal segment, that is your trunk, should be stable. If it is not stable, the distal component, that is your hand, will not act for reaching. There are 3 types of coordination that are defined. First is the interlimb coordination. So interlimb coordination occurs in 2 segments of the same limb. For example, if you're lifting a glass of water and drinking it, if this is your action, then this is an example of a interlimb coordination, because only elbow and hand are working in the same upper limb, and there is an alternating movement of flexion and extension of the elbow. So this is termed as interlimb coordination. So interlimb coordination will be coordinated movements in the same limb between different segments, right? Intralimb coordination, it is mostly seen in bimanual activities, wherein both of your upper limbs have to work together, right? Say for example, if you're buttoning a shirt or unbuttoning a shirt, if you're trying to dress yourself, right? So you are going to require both of your hands, and you are going to require both coordinated movements of both the hands, equal amount of contraction, equal amount of speed, so that there is no jerky movement, and the action is carried out smoothly. Next type of coordination is visual motor coordination, which is eye-hand coordination. So if I want to reach for an object, my eyes are going to first locate the object, then the visual stimulus is going to get registered in my neural system and tell me where the object is located and for how far my hand should reach. So that is visual motor coordination. In intralimb coordination, there is another example, like when you're walking, right? So when you're walking, there are alternating movements of your upper limb and lower limb. So if the coordination is affected, then there will be no alternating or reciprocal movements of your upper limb and lower limb. Moving on to the neural control. Now, as we all know, coordination is a part of the nervous system. It is controlled by the nervous system. So there are going to be some parts of your brain which are specifically designed, which are with whose function is to maintain the coordinated or carry out the coordinated movements in your body, right? So let's see the components of neural control, how coordination is controlled by the nervous system one by one. So the central elements is divided into three hierarchical levels. Before moving on to this, I would like to just revise a little. The nervous system is divided into a peripheral system and a central system. So the central system consists of your brain and spinal cord, right? And the peripheral system will consist of your receptors and spinal nerves, peripheral nerves, right? So here, in relation to coordination, the central elements are going to be the central elements are going to be divided into motor cortex, basal ganglia, and cerebellum, and there are no peripheral elements. So the neural control for coordination is carried out by the central elements. Okay, so they are divided into three hierarchical levels to assist understanding their organization as well as delineating the contribution of each neuroanatomical structure. So even though they are defined as three hierarchical levels, it is not necessary that the approach is always going to be from the higher centers to the lower centers. Okay, each and every part of the nervous system involved in coordination has distinct function, and if there is no synchronization between these central elements, coordinated movements cannot be carried out. Okay, so even though it is divided into three hierarchical levels, it does not imply a strictly top-down control of coordinated movement, as each level of the nervous system can influence other levels. Other levels, it can be either above or below, that is higher or lower, depending on the task demands. So the first level, which is the highest level, is represented by the association areas of neocortex and basal ganglia of the forebrain. So it is concerned with strategy. So strategy in the sense that the goal of the movement and the movement strategy that best achieves the goal. So if I want to carry out a certain action, right? So what my goal is behind that action will be determined by the highest level, that is your neocortex and the basal ganglia, right? What movement strategy, what amount of or what action should be carried out in what joint, that movement strategy will also be defined by this center as well. Okay, then the middle level, which is the second level, it is represented by the motor cortex and the cerebellum, and it is concerned with tactics. So the sequence, tactics in the sense, the sequence of muscle contraction arranged in space and time required to smoothly and accurately achieve the strategic goal. So the neocortex and the basal ganglia are going to just tell you what movement strategy to use, but the motor cortex and the cerebellum is going to tell the body how the muscle contraction should be carried out. Like if I want to reach for an object, so first my proximal is going to act, then my distal is going to act. So first I will require muscle contraction in the shoulder, then I will require muscle contraction in the elbow, then I will require muscle contraction in the hand, or simultaneously in the elbow and the hand. So these sequence of muscle contraction will be determined by motor cortex and cerebellum. Then the lowest level of the hierarchical system is represented by the brainstem and the spinal cord, and it is concerned with execution. So activation of the motor neuron and the interneuron pools that generate the goal-directed movement and make any necessary adjustments of posture. So now that the body knows what sequence should be started for me to be able to reach an object, the cerebellum the brainstem and the spinal cord will come into action, wherein uh, the brainstem and the spinal cord will retune or refine the movement so that there is appropriate reaching for the object, that the distance to be measured, the distance to be reached is determined here, and if there are any errors in the movement, then they are corrected by the lowest level. Again, not necessarily, even though they are divided into 3 levels, not necessarily it is going to go in this form, in this in this form. So let's see all the characters, all the parts of the coordinated neural control of coordination one by one. So first time we are going to discuss about motor cortex. Motor cortex is involved in planning coordinated movement to accomplish a task, right? So it is not just one area in the motor cortex that is going to help in carrying out the coordinated movement, right? So there are many areas which are involved, and how do they carry out is the motor cortex will send signals or register the body's position in space. It will also register the location of the intended target. Then it will be involved in selection of an optimum movement strategy, that is which joint, muscles, or body structures will be used. Then memory storage until time of execution. So here memory storage plays an important role, because if I am lifting a new object, right? I won't be able to lift it as effectively or as in a coordinated manner as I would some other object which is already stored in my memory, because the body already knows, or the nervous system already knows what the shape of the old object is, what the shape of the old object is, how much is the weight, what is the size, what is the size, how much mass the object is carrying. Okay, so this memory, the objects that are stored in the memory are easier to lift because already the brain knows what or how much movement is required. Then specific instructions to implement the movement strategy selected. That is where to move and what to do, like how much the movement should occur and where the movement should occur. Okay. So two distinct areas are defined in the control of coordination, which is area number 6, which is involved in intricate coordinated movements involving multiple joints. So area number 6 is further divided into two other areas, which is supplementary motor area and position motor area. So supplementary motor area is a part of area 6, and it is involved in initiation of movement. Its function is to initiate the movement, simultaneous bilateral grasping movements, sequential tasks, and orientation of the eyes and the head. So as we discussed before, that visual motor coordination is will be required in any of the tasks to be performed, right? So for that to be able to happen, eye-hand coordination for the eye-hand coordination to be to occur, supplementary motor area is responsible. Then position motor area, it will control your trunk and postural proximal limb movements, and also contributes to anticipatory postural changes. So if I am trying to reach an object which is kept far away from me, so only extending the upper limb is not going to help, right? I will have to also move the trunk, right? So moving the trunk and coming back to the previous position when the object has been lifted will be carried out by the position motor area. Okay. The next area which is involved in functioning of the motor cortex, with smooth functioning of the motor cortex, is your area 4, which will help in uncomplicated movements of a single joint. Then moving on to the next part is your cerebellum in the nervous system. So cerebellum, it functions as a comparator and an error correcting mechanism. So as the name suggests, comparator is wherein the movements of the new movements that were performed and the movements that were stored in the memory are going to get compared, right? And the cerebellum is going to address the errors in the new movement as compared to the movement that was performed before, and refine the or retune the movement so that the movement is carried out in a smooth, accurate fashion. It also it compares the commands for the intended movement transmitted from the motor cortex with the actual motor performance of the body segment. Okay, so what signals have been or what instructions have been given from the motor cortex to the cerebellum? Cerebellum registers it and it compares it with the movement that has actually occurred, right? So if there is any discrepancy in the movement that has been occurred, the it is a job of the cerebellum to recorrect and maintain the smoothness of the movement. So this will occur, the comparison will occur by comparing the information received from the cortex with that obtained from the peripheral feedback mechanism. Peripheral feedback mechanisms will involve your receptors, your joint receptors, your cutaneous receptors, which will give information according to the object that is placed or according to the movement that is happening, which is also termed as feed-forward control. Then once this is done, the motor cortex and the brainstem motor structures, they will provide the commands for the intended motor response. That is what to be able to reach, what sequence of movement is required in the body, which this is also termed as internal feedback. Then peripheral feedback during the motor response is provided by muscle spindles, Golgi tendon organs, joint and cutaneous receptors, as I said before, and vestibular apparatus and the eyes and the ear. So visual stimulus will be required or auditory stimulus will be required to locate the object, right? Once the object is located, then the if I want to lift the object, then the sequence of movements will occur. Okay. Then this feedback, it will provide continual input regarding posture and balance, as well as position, rate, rhythm, and force of slow movements of peripheral body segments. So if the input from the feedback systems does not compare appropriately, like I said, if the intended movement and the movement that has actually occurred are not similar, then the cerebellum will supply a corrective influence. That is, it will refine and retune the movement so that the movement that has already, the movement that is supposed to occur will be smooth. This effect is achieved by corrective signals sent to the cortex, which via motor pathways modifies or corrects the ongoing movement. Example, increasing or decreasing the level of activity of specific muscles. So if there is an object that is placed a little far away from me, okay, if I only extend my upper limb, then I won't be able to reach the object, right? So here the error is going to be that I did not flex my trunk, or I did not bend forward so that I could lift the object. So in the next repetition, when I'm reaching the object which is placed far away, the cerebellum will make sure that I'm also bending forward to reach that object which is placed far away. So it also functions to, the cerebellum also functions to modify cortical commands for subsequent movements. Like if I am doing if I'm lifting the object and taking it towards me, right, and placing it again on the designated place. So these subsequent movements will also be modified according to the cortical commands by the cerebellum. So the third part in the neural control is the basal ganglia. It functions in the following ways. So it will help in initiation and regulation of gross intentional movements. It will plan and execute complex motor responses. It will facilitate the desired motor responses while selectively inhibiting the others. And it also has the ability to accomplish automatic movements and postural adjustments. So any time the movement that is to occur, the initiation will be done by the basal ganglia. Basal ganglia is going to tell or send signals to the motor cortex that yeah, I want to do this movement, right? So you need to initiate the movement before before the actual movement that has occurred. Okay, what movement to do, which motor strategy to use. This is also planned by the basal ganglia, as well as if for the limb to be able to smoothly do the movement, certain other movements have to be inhibited, which is also facilitated by the basal ganglia. In addition, the basal ganglia it also plays an important role in maintaining normal background muscle tone. This is accomplished by the inhibitory effect of the basal ganglia on both motor cortex as well as lower brainstem. So now, in a normal individual, the muscle tone is going to be normal, right? But in a person who has increased muscle tone, it will be very difficult for that person to be able to carry out a coordinated movement, a smooth coordinated movement, right? Because since the muscle tone is altered, the basal ganglia cannot efficiently regulate the muscle tone, right? So in a normal individual, when the movement is occurring, the basal ganglia makes sure that the muscle tone is optimal, right? It is not increased, or it is not wherever there is requirement of an increased tone, the basal ganglia is going to increase the muscle tone and regulate it according to the movement that is supposed to occur. The basal ganglia also are believed to influence some aspects of both perceptual and cognitive functions. The basal ganglia is going to have an inhibitory effect on the motor cortex, so that there is no alteration in the muscle tone that is happening. Okay. All right. So before moving on to the impairments, I would like to just summarize the neural control. So basically, as we saw the levels of neural control. So the highest level consisted of the neocortex and basal ganglia. Then the middle was cerebellum and motor cortex, and the lowest level consisted of the brainstem and the spinal cord. Each of these parts of the nervous system will have a different role in carrying out a coordinated movement. So moving on to if any of the part of the nervous system which is involved in the functioning or maintenance of coordination is affected, the coordination is going to be the movement is not going to be smooth, accurate, or carried out in a sequential manner. So let's see the impairments one by one. First is the cerebellar pathology. So if the cerebellum is affected, then the incoordinated movements that are seen are asthenia, dysarthria, dysdiadochokinesia, dysmetria, dysynergia, gait ataxia, and hypometria. So asthenia is basically a generalized weakness of the muscle. Dysarthria is where it is a disorder of speech, wherein there is a problem with the motor part of the speech, that is the articulation of the speech. So it might result in a slurred speech, or the subject or the patient is not able to understand, not able to speak, but is able to understand what you are saying. Then dysdiadochokinesia is a impairment with rapid alternating movements. So if you ask the person to alternately do supination and pronation of the forearm, the person or the patient will not be able to do it if he has cerebellar pathology. Then is your dysmetria. Dysmetria is a difference or lack of judgment in the distance of the object. So how much I have to reach, how far is the object placed, that distance is not appropriately judged by the subject. Then dysynergia, and then gait ataxia. Gait ataxia is where it is actually characterized by wide base of support and postural instability. It is most commonly seen in affection of cerebellum. Then hypometria is where the judgment of the distance uh, is going to be like the movement is going to occur uh, in a way where the distance is short. Like if the object is placed at a certain distance, the movement will occur and the movement will occur, but it will not reach the object appropriately. Next is your basal ganglia pathology. So if the basal ganglia is involved in any way, these are the impairments in coordination that can be seen, which is akinesia. So akinesia is basically absence of coordinated movements, which is actually seen where in cases where there is postural involvement, like in Parkinson's. Then athetosis. Athetosis is writhing type of movement, which are mostly seen in distal part of the upper extremities. Then bradykinesia is a paucity of movements wherein the amplitude and the velocity of the movements are amplitude and velocity of the movements are decreased. This is a classical clinical feature of Parkinson's disease. Then chorea is where it is an involuntary movement which occurs in your upper extremity. These are jerky, rhythmic movements. It is different from athetosis because in a way where athetosis are like worm-like movements, and chorea is going to be jerky. Like it will have a certain frequency, it will have certain repetitions. Then dystonia is wherein there is a particular sequence of movement that occurs whenever the subject is trying to reach for an object. Then hemipallismus is large amplitude movements that occur in all of the upper extremity. So chorea or athetosis, it is mostly present in the distal upper extremity, but hemipallismus can occur in whole of the limb, whole of the limb. Like in cases in persons where there is flailing of arms, like those are large amplitude movements, right? Then hyperkinesis and rigidity. Rigidity is increased in muscle tone in both group of muscles, that is agonist as well as the antagonist. And then tremor. In basal ganglia pathology, the tremor that is seen is a resting tremor. That is when the patient is not doing anything or not performing any movement. That is when the involuntary movement occurs. This is also a classical feature of Parkinson's disease. In the next part, we will be discussing about assessment of coordination. That is how coordination is assessed and what is the interpretation. Thank you. I would also like to thank Dr. Parag Sanjeevi sir and Manisha ma'am for constantly guiding us and supporting us. Our beloved principal, Dr. Apurva Shimpi sir, for giving me this opportunity to record a PhysioTV classroom session, to take a PhysioTV classroom session. Our tech team, which without them, this session won't be conducted as smoothly as it is right now. And a very big thank you to all the viewers who religiously make it a point to watch these sessions. I will see you in the next session. Thank you.